Welcome to the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. To watch the video of this podcast, you can subscribe to Natasha's channel on YouTube and follow her professional Facebook page at Natasha Helfer, LCMFT, CST-S. You can also find all her cool resources at natashahelfer.com. The information shared on this program is informational and should not be considered therapy. This podcast addresses many topics around mental health and sexuality and may not be suitable for minors. Some topics may elicit a trigger or emotional response, so please care for yourself accordingly. The views, thoughts, and opinions expressed by our guests are their own and do not necessarily reflect the views or feelings of Natasha Helfer or the Natasha Helfer Podcast. We provide a platform for open and diverse discussions, and it is important to recognize that different perspectives may be shared. We encourage our listeners to engage in critical thinking and form their own opinions. The intro and outro music for these episodes is by Otter Creek. Thank you for listening. Hello, everybody, and welcome to the Natasha Helfer Podcast, where we go after shame anywhere we can get it, especially in the realms of religion, sexuality, and mental health. Three pretty taboo topics in culture still, so we have lots of work to do. And before we get started with my guest, I just want to remind everybody that I have the upcoming ketamine group for healing male sexual shame. I also have some groups coming up for religious trauma, reclaiming female sexuality, and navigating ethical non-monogamy, and also navigating mixed orientation marriages. So if any of those realms apply to you and you're interested, contact my office at Symmetry Counseling and we'll give you more information. But without further ado, I am so excited to have our guest today. I have Dr. Pebble Kranz. I have met Pebble. Is it okay if I call you Pebble, by the way?
Please do. Yes, absolutely.
Once we earn those doctorates, sometimes it's like, just call me doctor or whatever.
No, not me. I'm a former theater chick. The transition to being doctor was very hard.
I love it. Well, I've met Pebble at several ASECT conferences and also ISHWISH conferences because of our intersection in our work with sexuality. So I'll read off a little bit of a bio, and then I'm so excited to talk to you about the topic today, which is really the intersection of cancer and sexuality. So Dr. Kranz is a family physician and sexual medicine specialist, graduated from Brown University's medical school in 2007. She completed residency with the University of Rochester Family Medicine Residency Program in 2011 with a focus on psychosocial aspects of primary care. And after serving as residency faculty and a primary care doctor for the University of Rochester, she pursued additional training in sexual medicine and gender medicine, earning fellowships from the European Committee on Sexual Medicine and the International Society for the Study of Women's Sexual Health, which that's ISHWISH, which I say ISHWISH like people would know what that is. That's what it is. She's a founder and medical director for the Rochester Center for Sexual Wellness, providing comprehensive care for sexual, relational, and gender concerns in Western New York. She serves on the board of the Scientific Network on Female Sexual Health and Cancer, and is committed to educating healthcare professionals at all levels and the community on medical care for sexual concerns. So that's a lot, and it's wonderful. And I'm so excited to have you on the show. Thank you for coming on.
Thank you so much, Natasha. I'm delighted to be here.
Yeah, and this is an intersection that's so important. We talk about it all the time at certain ASEC conferences. Most of us are therapists, and we're constantly like, oh no, what's happening in the medical field, and why are our clients not always getting sexual health education, especially with some of these very profound treatments and diagnoses that people get that are scary and difficult, such as cancer would be. So give us a little bit of insight of what it's like on your end, and how much sexual health training do you get, and why did you decide to get these extra trainings? Why was that important to you?
Well, there are lots of ways to tackle that question. So there's the question first of sexual medicine altogether. Um, why did I end up here in sexual medicine? Family medicine is incredibly rewarding. It was really people's stories that got me into family medicine. And I realized as a family physician and as a faculty on a residency faculty that I really knew nothing to help my patients with their sexual concerns. And this came to light because my husband is a sex therapist. And so I would go home and I would hear about what he was hearing from his patients. And I would feel like, oh, wow, I don't really know how to help that person. I went to some ASECT conferences and really learned about um, how unhelpful, if not harmful, a lot of medical providers are in terms of people's sexual well-being. And I realized I just wanted to learn more, and that this was a piece of people's stories that was really important to me, that I was missing. And so I pursued training in this area because we, in general medical training, get very, very little, right? In general, the general community, we get very little sex education, but the medical community isn't getting a whole lot more beyond reproduction and infectious disease. And there are so many ways that medical conditions can impact sexuality. There are so many ways that all the treatments we provide impact sexuality. And so as I began to learn, I really realized that this was something that I wanted to focus my attention on. And then getting into cancer and sexuality came out of I went to a talk by one of our gynecologic oncologists, and I just went up to him and I said, people that you see, your patients need my help. And he said, you're right, they do. And then he helped me start a clinic in the University of Rochester's gynecologic uh, oncology department, so women's cancers. So it was really from both sort of seeing the needs of the people who I uh, saw as a primary care doctor, and then really getting this amazing opportunity to talk to so many people with a cancer experience in the gynecologic oncology department, and realizing that it ended up being some of the most rewarding sexual medicine work that I do, because there are so many things that can be done to help people with their sexual well-being after a cancer experience, during a cancer experience, and they're just not getting any of it. They're feeling like this is sort of a casualty in the war with cancer, right? And it is there. It's just not necessary for people to be feeling that way. There's so much that can be done to help people with cancer and their sexual well-being. So,
Okay. Yeah. And as you got these extra trainings, were you like, holy cow, kind of like when I went to get extra training as a sex therapist and I was like, holy cow, were you kind of
all
like,
the things I don't know, right? Yes, right. I didn't know how
I
much.
not get trained in this, right? Yeah.
Right. Yeah.
Right.
How
Yeah.
can I responsibly be out there saying that I'm providing medical care when I'm missing this big component of people's lives?
Well, and I think that says a lot of how we treat sexuality, right? Kind of like an auxiliary or an extra. And you shouldn't, if you don't get to have good sex or have good sexuality, well, then, oh, too bad. But it
Right.
instead seen as an integral part of people's identities and wellness and health and even health planning, right? Yeah.
Yeah. Yeah.
Okay, so oh, go ahead. Were you going to say something?
I was just going to say, it it's remarkable, um, the the statistics around the people with cancer who have sexual concerns. So up to 90% of people with breast cancer, nearly 100% of people with prostate cancer, 75% of people with gynecologic cancer. There are a lot of people with a lot of distress, and almost no one is getting asked about it by their oncology providers, their nurses, their whole medical team, let alone their primary care doctors.
Yeah. Wow. Okay, well, let's go into a little bit of that. I don't know if you have stats in front of you. I listened to one of your presentations, so I have some of your slides in front of me and I can help you out. But just like the prevalence, right? Like what are you just named off some different types of cancer? What's the general prevalence and what are some of the statistics around how some of these cancers do affect sexuality?
I mentioned some of the kinds of cancer that we know more about the sexual impact of the treatments for those cancers because they are kind of cancers that affect our sexy bits, right? And so in those cancers, we don't talk about sexuality and how to help people with sexual concerns enough, but we do better in terms of those kinds of cancers as compared to all the rest. But every single kind of cancer, the treatments of every single kind of cancer have an impact on sexual well-being, or can, so head and neck cancer. A lot of our sexual connection is done with our mouths and our tongues. Anything that affects the skin has sexual impact. Anything that affects anything in the pelvis, the colon, the bladder, also the kidneys, all of these things can have an impact on sexual function. Of course, not because of the cancer itself generally, but because of the treatments.
Right, because there's
So, yeah,
aggressive oftentimes and invasive, I'm assuming, as far as chemotherapy, for example, radiation. I'm
right.
assuming that's going to affect all the cells, not just the ones we want to kill off, right?
That's right. Yeah. So chemotherapy, radiation, they all affect quickly growing cells. So cells that turn over quickly. And the cells that turn over quickly are the cells in our gonads, our ovaries, and our testes. They're the cells in our skin. They're the cells in our GI tract and the skin of the vaginal canal. The skin of the mouth. All of these quickly turning over cells are attacked by most kinds of chemotherapy and radiation. And then, of course, surgeries have an impact too, right? By changing parts of the body. Um, or even if it's not changing parts of the body that are used for sex, that we think of as a sexual part of the body, it can be changing our blood supply and changing our nerve function. So those things can have an impact on sexual function as well.
Yeah. Okay. So you had this really lovely, like kind of all these circles of things that can affect. So I'm gonna just kind of start with some of those and hope that you'll, just give us a little bit more insight. So for example, desire concerns. That's a very typical one where we know that medications, even how you think about yourself, even the idea of being ill, all of that can impact our drive, our sexual libido. Is that fair? What do you want to say about that?
Yeah, so there are a variety of components of our experience that affect desire. So certainly, a change in the hormonal environment may have a profound impact on desire. The sudden menopause symptoms or the hot flashes that can go along with hormone suppression treatments for prostate cancer, for example. Um, these can disrupt sleep, which disrupts sleep, and our sexual response are very tightly tied together. So it's very hard when we're exhausted and feeling ill to feel sexy and to feel motivated towards sex, right? It's just a different priority. Um, and then there are a lot of the medications that we use to help people with other cancer treatment side effects. So, like nerve pain, the medications that we use for nerve pain can delay orgasm and decrease desire, decrease arousal. The medications that we use for mood changes in the wake of a cancer diagnosis, all of those can also have an impact on desire, arousal, and orgasm. And then there is also, when we have less arousal and we're enjoying less, when we get less reward from sexual play because the orgasm that we've come to enjoy has changed or goes away. And certainly, if there's pain with any aspect of sexual play, um, this makes sex pretty unappealing. It would for anybody, right? And so I always say to people, I quote Peggy Klein Platt's low desire may be a healthy response to sex not worth having. So the problem there isn't really the desire. The problem is, let's make sex worth having. Let's make sure you don't have pain. Let's make sure you're having arousal and enjoyment, and having an orgasm experience if that's important to you. So there's that piece. And then, of course, cancer changes how we feel about our bodies in a wide variety of ways. So it can change how we look. And that's what we talk about the most, if there's a hair loss or a mastectomy, there's a change in weight. All of these things can have an impact on how one feels sexually, but then it also changes the relationship with the body. And I think that this is something that is really not talked about enough. That sense of vigilance that a lot of people have towards their body's experience after cancer, where they feel like every sensation or thing that feels out of place is a sign that the cancer might be coming back, right? So there's that sort of mistrust of the body that can happen. And then everything we're doing in medicine is very invasive and really requires this distance from the body that is really functional to get through cancer treatments. If you feel disconnected from the body, then it's easier to tolerate all of these invasive, difficult, sometimes painful things that are happening. And then reintegrating that is really complicated. And so that has an impact on desire. It has an impact on arousal. It has an impact on how we conceive of ourselves as sexual beings, in every way. So, and I'm sure there's some things that I missed there.
No, that was it's really good. I want to just go into them a little bit better, because you did have one of the circles was desire concerns, another circle was arousal concerns, which you're bringing up. another one, orgasm concerns. I'm not sure everybody always delineates between those three things, like when we talk about sex. So can you even talk a little bit as a physician, how you would delineate between talking to somebody about issues that might come up with desire versus arousal? How would you?
That's a really good question. Yeah, because people come and they say, my desire has gone. And actually, what they're experiencing is that they're not having blood flow in their genitals. Right. And so when I'm I talk about all of these domains, which often overlap when people have sexual concerns. Desire is your motivation. It's your interest. It's the sense of being willing or receptive, and sort of the willingness or motivation to just sort of see what happens with one's body in a sexy situation to see if it feels good, right? So that is very different from, are you having blood flow into your genitals? For people with vaginas, lubrication. For people with penises, erection. And of course, clitoral erection for people with clitorises, with vaginas, and that there's that physical component of arousal, and then there's a mental component of arousal. So, are you cognitively enjoying? So that's different from motivated and wanting. Are you in a place of enjoying in your brain? And then if you don't have enough arousal, that's one of the components that can get in the way of orgasm, that sense of release, that rhythmic pulsation of the pelvic floor, ejaculation, perhaps, if that is something that happens with orgasm for that person. So for instance, after prostate cancer, orgasm possible, ejaculation usually not, right? So that's sort of how I describe those different kind of phases. And
yeah, I love that. I think, and I appreciate that you bring up arousal has psychological components too, because how I usually explain it is like, desire is our want to want. Arousal is more like the physiological aspects of. So, for example, you can be in an experience where you don't want to be there, like a sexual assault type of experience, and your body may respond with arousal, but that doesn't mean you wanted whatever.
Or that you're enjoying.
You're enjoying it, right?
Right, yeah.
Right. And then there may be a lot of want, and even arousal, like psychologically, like, oh, this is fun, but darn it, I'm not getting an erection, right? Or I'm dry and I need some lube. And so that's, your body isn't necessarily it's not following through with your desire.
Right. Yeah. So we do, when I talk with patients, we're doing a lot of like, okay, so is it this component that is it the wanting? Is it the enjoying? Is it the genital? What's happening at your genitals? Which component is this? And this is one of the reasons why it's hard to take medical care of sexual concerns in primary care or in general care, because it's hard to figure out. It takes some time, right? It takes more than 7 minutes.
Yeah, right. I would say it takes sometimes more than 7 months of being in therapy. Somebody will tell me something. I'm like, wait, hold on. I think we missed something. I didn't know this about you. I either didn't ask the right question, or we weren't, concentrating about this particular, we assumed it was this other thing. And so
Right?
that's challenging for sure. Okay, yeah. So desire, arousal, orgasm concerns. Maybe you're not able to have the same type of orgasm, or it takes longer to have the orgasm, which of course is frustrating. And there's grief and frustration with that. That's what I work with a lot of people on post
Mm,
cancer. You mentioned sexual pain, and also another circle that you had was erogenous zone sensation changes, right? So, for example, people with mastectomies, or people with clitoral cancers, or even testicular cancer, or so now all of a sudden, even after people have, I guess, recovered or in, remission, there's a sensation change. My nipples are not having the same sensations, or
right.
how my partner used to touch me that was so indicative to, we knew that would work, now it doesn't work anymore, or things like that. So maybe, yeah, sexual pain and sensation changes. What
Yeah.
are the typical concerns you hear about there?
Well, so, we discover what feels good in our bodies when we're pretty young, right? And that's an evolving experience across time, but particularly when someone has sort of gotten used to, well, nipples were my on button, right? What do I do now that I don't have that on button anymore, you know? And then certainly, penile cancer, vulvar cancer, these are things that can affect, you know, genitals profoundly, including our ability to have physiologic arousal. And sometimes, like, uh, nerve issues that go along with either numbness or nerve pain that goes along with cancer treatments like chemotherapy. These things can sort of change what feels good. My aunt had a cancer, and she went from being a person who loved cinnamon and the smell of coffee. Like, these were real pleasures for her.
Yeah.
And in the wake of her cancer treatments, coffee and cinnamon became awful scents. Like, they were there, all of the pleasure of those things got taken away, right? So there are really diverse ways that all of our sensory engagement can change, related to a cancer experience. And I'm realizing that, like, I'm talking, and we're going to get to things to do about all these things, but like I'm noticing that we're talking about all the things that can go wrong, and
Oh, right.
um, one might feel a little hopeless about all this, but there are things to do, right? So sexuality may change, like you mentioned, the grief and the loss of one's relationship with the body in the past, and one's relationship with a particular kind of sex, perhaps, um, but that doesn't mean that human beings are not able to find new ways to have pleasure. It's a evolving process. But so then the other thing you asked about was sexual pain. So generally, this is an issue for people with vaginas, that can be related to decreased lubrication, dryness, or related to having had radiation to the pelvis that causes a shrinking of the skin of the vaginal canal. Um, it can also be related to pelvic floor muscles being tight because of the surgical alterations, or because of tension around the part of, your tension around your pelvis or related to nerve changes, right? So all those pelvic floor muscles can also contribute to pain. Um, and then there, this also is something that can happen in people with penises. So after prostatectomy, for example, after colon cancer, there can be pelvic floor muscle changes that can create pain with orgasm or pain with arousal. Um, uh, the those there can be changes to the skin, certainly if one has had pelvic radiation and one's preference is for receptive anal sex, then um, the changes to the skin of the rectum and the anus, these can have cause sexual pain. Um, so it's not just people with vaginas that have problems with sexual pain, though. That's really mostly.
Yeah, right. Okay. So yeah, and then you had already mentioned the last, well, I think you mentioned the last two circles. One was body image and body disconnection, which of course, yeah, if we're getting like you mentioned, hair loss or mastectomies or removal of a testes, or like we have feelings about our body parts, right? And a lot of times, especially if they're things that are tied to kind of roles around masculinity or femininity and how we feel sexy, like, you know, my long hair helps me feel sensual and all of a sudden I'm bald, what does that do to my connection with my sexuality, right? Or if my breasts, you know, and some people don't care as much. It's like, you know, just lob them off and I could care less. They're killing me, right? And other people are like, oh my gosh, this is like a part of who I am. And so even just the reactions that many different people will have over the same surgery, I'm assuming
Right.
varies dramatically.
Yeah. Yeah. And I think that sometimes it's sometimes it's super obvious to people that, oh yeah, this is going to be a problem for me, right? And other times it is just not clear until it happens. Um, how uh, how it was
Mhm.
an important part of one's sense of self, this
Wow.
body part.
Wow.
And yeah, and so much of the not visible. I mean, even people with hysterectomies
Mhm.
sometimes feel like um, this is this was for me what it meant to be a woman, right? That there was a uterus in me.
Mhm.
And so because we don't see it, right? We don't see that a uterus is gone.
Right.
Um, that becomes one of these things that people have disenfranchised grief about and like no place to talk about. That oh, this body part was really important to me, and I have everybody who I say I can't believe I don't have a uterus now says, well, you look fine. I couldn't even tell, right? You're not getting it. That's how I
Yeah.
feel.
Right. Exactly. And then you had mentioned like inhibitions, and in your slide you had like fear of sexual play. So this is kind of like you feel more fragile, or maybe your partner feels like you're more fragile, or so maybe rigorous sexual activity that we used to do now feels maybe unsafe or something. Is that a concern that comes up?
Um, I certainly it can come up. So in a couple of different ways. One way is sometimes, particularly for people with some kinds of gynecologic cancers, sex was the way that cancer came to light,
Mm,
right? It was the bleeding after sex, or it
mm,
was the pain during sex that led to the cancer diagnosis. And so this can create a lot of vigilance and a discomfort around sexual play. Um, and uh, and then also, yes, just sort of worrying about the fragility of a partner. Worrying about the fragility of oneself is, are my parts going to work the way that they worked in the past? I don't know what to expect, right?
Yeah, for sure. Okay. So we've addressed many of the issues. So now let's talk about, like you mentioned,
Solution.
so what do we do? Are we doomed? So
No,
I don't think we're doomed.
no, we are not doomed. We are not
So how do
doomed.
you want to talk about this as far as like what kind do you have, like, okay, these are the kind of solutions, or depending on the types of cancer, what's your best thought about how we go into, okay, addressing these many things and what solutions exist?
Yeah. So there is a solution for almost any sexual concern. We are evolving creatures when it comes to our body's pleasure and what feels good. And we're sexual beings whenever we want to be, right? From the cradle to the grave. So that is fundamentally true. The other thing that is fundamentally true is that change to how we experience our sexual well-being is inevitable. I mean, it's inevitable with age, it's inevitable with any number of other things, but with cancer and cancer treatments, it tends to be sort of a more sudden change. And for this reason, can feel additionally difficult, right? And so the first thing is to really think about what sex means to you. What does your relationship to your body mean to you? What does your relationship to your pleasure mean to you? And it may require some flexibility with regard to how you engage in pleasure, how you engage in sexual play. Um, there may be changes in what feels good. So, uh, some like 1 to 4% of people after prostate cancer have better orgasms than they have ever had.
Mm,
Right? Some
wow.
people with breast cancer, after mastectomy, after other treatments, have the best sex of their lives, right? So it's not a given that all of those changes are going to be losses. So that's sort of the baseline. So,
I think that's a really good place to start, because I think I was like, I'm like the yes and. Yes, we can be sad. Yes, we can be angry. Yes, life is unfair. Yes, we have to do that grieving, frustration, anger work. And who knows what's ahead, right?
right,
Because we are very adaptable creatures.
right.
I remember one time, this wasn't cancer, but I think it was Christopher Reeves who was talking about, after his paralysis, how they, are still sensual and sexual as a couple, which, he's paralyzed from the neck down. So obviously he's
Mhm.
having a very different type of sex than he would have had
Right,
prior to this accident. And yet our bodies attune differently. There's different areas of our bodies can become erogenous zones that we didn't even pay attention to when we had maybe clearer erogenous zones to play with.
right. Yes, right, right. Yeah, yeah. But and I think that sense of openness to new experience um, is so dependent on our ability to do the grieving that things have changed, right? Um,
That you
and
see more potential for pleasure if we're being real about the grief versus just trying
yeah,
to stuff it away or pretend it's not there or that it's no big deal.
right, right. And that's true of partners too. I mean, we're talking about things that are happening um in a body, but if you're in partnerships, then there are changes that are happening for partners as well. And they need space for grief and possibility too.
Yes.
Um, so the problem, I think, with a lot of conversations about cancer and sexuality, though, is that that's where the conversation stops, right? There's hope, things can change in a better way, grieve the past, and then that's that's all the help I get. Ooh.
We're missing
And
the how, like
yeah,
how did we get there?
right. And all the things that can be done to help with arousal, the wide variety of ways that we can help people with penises have erections. When it comes to erections, it is almost where there's a will, there's a way. If you want erections, we have a way to make them happen medically,
Mhm.
right? Um, Now, erections are not so simple, right? And it may require a variety of different kinds of interventions that one needs to try. Certainly, it requires an environment in the rest of the body that is conducive to that arousal. But um, the when we have oral medications, we have pills, but then we have injections and pumps and 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 surgical procedures that work really, really well for the people for whom uh, that's the right choice, right? So there are plenty of ways to have erections for the vast majority of people. There is a lot to be done about vaginal skin care, vulvar and vaginal skin care, and blood flow to the clitoris to help with arousal for people with clitorises and vulvas and vaginas. So um, we there are ways to use both non-hormonal moisturizers in skincare. And for the vast majority of people, using topical hormones is really fine. It's really not a problem with most kinds of cancer. So if one has an active breast cancer, if one has an active uterine cancer of certain kinds, then we should try some other moisturizer, non-hormonal moisturizers first. But if those things don't work, topical hormones that go on the skin of the vulva and vagina, we now have so much more information to say even people with breast cancer, even people with hormone responsive breast cancer can use topical estrogen if the other methods haven't worked. So, and there are some in the sexual medicine community who say, look, we have enough data to say this is safe. Why are we wasting people's time on non-hormonal moisturizers? So, there are now 4 large studies that have been done in people with breast cancer with regard to topical estrogen, with non-hormone responsive cancers and with hormone responsive cancers. The overwhelming majority of the evidence is that this does not increase the risk of mortality, of dying, and it doesn't increase the risk of recurrence, the breast cancer coming back.
Wow. Okay.
So there's, there are changes on the horizon with regard to how oncologists are dealing with this. The difficulty, though, is that people are going to hear from physicians who don't have up-to-date information. They're going to hear from their aunt and their cousin, oh my God, what are you doing? Putting estrogen in your body with breast cancer, right? And so that's something that makes it very complicated, because we also don't want to increase somebody's anxiety about recurrence of breast cancer. So my approach with this is that we do everything that's possible with non-hormonal methods, but let's not take it off the table unless it's really like anxiety provoking to somebody who's had a breast cancer or a uterine cancer experience, some kinds of ovarian cancer.
Okay.
So there are some really simple things that people can do to take care of their vulvar and vaginal skin. So first off, no soap on the vulvar skin. No soap at all. We do not need soap on any skin that is not hairy. Hairy skin can take soap. Non-hairy skin does not take soap. The skin of the vulva, the inner labia, this is skin like our lips and just inside our mouths. We don't use soap there, right? Soap is drying, and so that can make it worse. The other thing that we can do is use a vulvar moisture barrier, so a natural oil, olive oil, coconut oil, on the external skin of the vulva to help keep the moisture in. And then we have moisturizers to go inside the vagina. The key thing here is that some are not properly formulated for the vaginal skin. So Replens, for instance, actually draws moisture out of the vaginal skin cells rather than pushing moisture in. So, some people are like, well, I tried that Replens, vaginal moisturizers don't work. Well, there are a whole host of other kinds that may be helpful.
Wow. Okay.
So that's the arousal piece.
So there's products out there that are not necessarily doing what are advertised or that people are having different experiences with.
Right.
Which is really the importance of having a specialist on your team like yourself, because I'm guessing, I mean, I don't know if you would say this or not, but would you say there's even a difference between oncologists being up to date with all of these things and whether or not they've taken a sexual health interest? Oftentimes, even when I'm just talking about a psychiatrist versus a primary care physician, sometimes I notice primary care physicians are not adequately maybe trained as much on aggressive dosing. They might give a basic dose, but if you're one who needs a more aggressive dose, you're maybe not going to get that. And the importance of specialists.
Yeah. So that would be the other takeaway that I would say is, like, if you haven't been helped, it's not that you're not helpable. It's that you haven't found the right help.
Yeah.
And keep on looking for help until you get helped.
Yeah. Okay. So you're giving a lot of wonderful medical resources for both erections and also for lubrication for folks with vaginas and also vulvas. What else are we missing? What other options do you have that you're like, okay, here's a whole nother set of resources or ideas?
So orgasm concerns.
Yes.
Certainly one component is having enough arousal to have orgasm. That's a piece of it. The other piece of that can be that pelvic floor muscles may be tight. And so there isn't the flexibility in those muscles to have that sense of the rhythmic pulsation of the pelvic floor. And then the sort of the wiring to the brain about finishing gets kind of disrupted. So attending to pelvic floor muscles with pelvic floor physical therapy is one thing. The other thing is there are many medication adjustments that we can consider in order to have orgasm be more accessible. So if you're on boatloads of gabapentin for nerve pain, that's going to get in the way of your orgasm. And it may be that if there's another way to deal with the nerve pain, you may find your orgasm coming back. Or if you're on high doses of Effexor, venlafaxine, a medication for either mood or sometimes used for hot flashes, this also can be profoundly orgasm delaying. And so there are shifts to the kinds of medications that we're considering for these issues, because some of them, the issues need to be dealt with too. But there are other medication options that might not have the sexual impact in the same way. There are also, there's also the incorporation of more kinds of stimulation for orgasm. So bringing vibrators in, bringing in other kinds of mentally and physically arousing stimuli. It may be that you need more stimulation, not less. So we have this, this idea that as we age, we somehow, we can do the same thing to have the same amount of arousal, but it's not true. As Barry McCarthy says, we all need more fiction and friction. We need, as we get older, we need more that's arousing, right?
Right.
So those are some things, and certainly sexual pain has to be dealt with. It has to be dealt with by helping the skin, helping the muscles, helping the nerves, in order to allow for enjoyable, rewarding sexual play. And then in the realm of desire,
Are you talking about primarily penetrative play in the genital pain,
well,
or even other things?
so there could be pain with orgasm, right? There could be pain with ejaculation. There could be discomfort with arousal or pain with touch of the vulva. There could be pain in the hips, or the legs, or any part of the body, right, that is triggered by a sexual situation. There could, I had one patient who came in for low desire, and he had had a head and neck cancer, and he had a significant contracture of a muscle of his neck. And he was like, I don't know. I don't know what it is that I don't want sex anymore. And third session comes around, and it turns out, because of this muscular contracture, he's having explosive headaches with higher levels of arousal.
Okay. Yeah.
And he needs something to be done about this muscular issue, or a way in his sexual play to be able to relax and put that muscle at ease so that he doesn't have an explosive headache with sexual play. Of course he isn't motivated for sex, right?
Right. Absolutely. Okay. And I apologize, because then you were moving on to something else, I think, with arousal and desire, maybe, as far as.
Yeah. So, desire, as I mentioned, has to do with a lot of things, so it's not so simple. But there are certainly a number of things that are under investigation with regard to medications that may be helpful for desire. So, for instance, flibanserin, which is also known as Addy, or bremelanotide, which is also known as Vyleesi. These are being studied, flibanserin particularly, in cancer populations, and then bupropion also studied in cancer populations for helping with desire. And then again, our story around hormones and cancer is more complicated, right? We've gotten this message that estrogen is fuel to a variety of kinds of cancers, and that testosterone is fuel to prostate cancer, and that you shouldn't touch those things if you've had a hormone responsive cancer. Or if you've had, for some people, any kind of cancer. I've had somebody come in who's had thyroid cancer, and they're like, well, I can't use estrogen, can I? And I'm like, I don't see why not, because your thyroid has nothing to do with responding to estrogen, right?
Yeah.
And the story with estrogen, progesterone, and breast cancer, not so simple. The story with testosterone and prostate cancer, not so simple. And there are many times after a prostate cancer where we really can consider the use of testosterone, which can be profoundly helpful with desire, particularly in men who have low testosterone. So I don't, I'm not prepared to like go into the details of all that, but I would expect that over the next 10, 15 years, there will be more widely understood the idea that hormones aren't adding fuel to the fire. It's more complicated than that.
Okay. That's even groundbreaking for me to hear. I did not realize that as much, because I had heard, even just recently, I've had some friends with breast cancer who are like, yeah, I'm not going to be going with this hormone because I don't want to, take a risk or something. So this will be really interesting for me to go back and go, well, hold on, let's have this conversation.
Right. Yes. Yeah.
So yeah, that's really
Yeah.
important. Okay.
Yeah.
What are maybe some things that like, are people readily open to these kinds of treatments and interventions, or are there kind of maybe psychological things that you see as well that maybe people are hesitant or worried, or are they just like, thank goodness you're giving me information that I really needed to hear?
Well, sometimes it's simple and sometimes it's not so simple, right? Yeah. Sometimes we fix the arousal. We do some skincare and encourage people to think flexibly about their sexual scripts, and they're good to go, right? And sometimes more rigid sexual scripts, sort of a sense of this is how sex is supposed to go. If sex doesn't include these particular sex acts, these particular sexual behaviors, or this particular physiologic experience, then it isn't sex. So that when those scripts are really rigid, it is complicated.
More challenging.
Yeah.
Yeah, it's fascinating how so much of, this is why it's so important to have a team, right? We always talk about like the trifecta team is like, a medical provider who understands sexual science, a sex therapist, and maybe a pelvic floor therapist, right? Or, so you've got these people who can address, and how important it is, the psychological piece to so much of the medical piece, right? They're so integrated as far as our beliefs about ourselves, whether or not we're optimistic, whether or not we have growth mindset, whether or not we, have support in our systems, how our partner is supporting, whether or not a partner is an ally to the healing or not. So many components. One of the things that you talked about, which I'd just like to get your take on, is how oftentimes partners get left out of the medical kind of space. Is that fair?
Yes, more than fair.
Mhm.
I mean, this is true across so many areas. If we think about, people who are around the delivery of a child, right? We think about postpartum sexual well-being. For the most part, partners get really left out in the cold with regard to that, with regard to information and assistance, and it's even more so in this zone where um, perhaps partners are coming in to visits with oncologists as key supports, but uh, related to stigma about talking about sexuality. Perhaps the oncologist, even if they are sexual health versed, are not going to bring it up when the partner is there, right? And then we also, so Daniela Whitman and a group did a really beautiful set of guidelines about prostate cancer and sexual well-being and rehabilitation. And one of the key things there, as well as in other guidelines, is that it's really important to first raise the conversation. Medical providers should be raising the conversation, and we need to include partners to the degree that the person who um, has the illness wants their partner included, right? So we need to be checking in
Right.
about that. Um, Another thing that comes to mind is that one of the things that we really have done some research in cancer care, in mortality and illness, and health behaviors, is that dyadic coping, the way that partners react to an illness, the way that they work as a team around illness has an impact um, on mortality and illness, right? And so when there is a dyadic approach to the illness, we know things go better, a positive dyadic approach. And that's true of sexual changes too. So if that can be seen, if sexual changes can be seen as a we problem, not a me problem, that also goes a long way to facilitate improvement and well-being and more flexibility around sexual scripts. If your partner's on board with figuring out what feels good now, then you have a much greater likelihood of having some ability to explore that good feeling.
Yeah. Yeah. Okay. Well, yeah. So I know we're nearing the end of our time, and I know your time is valuable. And so what am I not asking you about that you're like, oh, people just really need to know this, or like, or maybe last thoughts that you have, or anything that you feel like I'm missing in what I'm asking you?
I don't think you've missed much at all. Um, so two things that I like to emphasize with people, and I've mentioned it a couple of times, but I think that um, this exploration of what feels good now, what is pleasure like in this body now, is the most important question that one can ask oneself. Um, and not just thinking about sexual pleasure, thinking about the smell of coffee and cinnamon, and maybe it's lilacs now, right? That, or maybe it's no sense at all, right? It feels the best to this body now. And as much as we can do to explore that question and be open to that question, the much greater likelihood of success.
Yeah.
I may have forgotten the other thing.
That never happens to me.
That's right.
Never.
It wasn't that important anyway.
Yeah. That's right. No, but I really love that reminder. And even the reminder that pleasure is not divorced from, like, I think sometimes when people think about, oh, I need to be good about pleasure and sexual pleasure and be open to that, I think there's sometimes surprise when I start with, well, what's your relationship with pleasure in general, right? Like, forget sexual pleasure. That's like, if you don't even know how to enjoy little moments of pleasure in your day-to-day life, how are we going to get better at this big pleasure, that is, takes more time and intentionality sometimes. So
Yeah.
noticing the sun on your skin, or knowing how to rest and have leisure in your life, and not being turned on 24/7 by our to-do lists, or things like that, can really help in that sense. So I love those questions. What feels good now, and what is pleasure like, and what's my body doing now? Which also taps into that resilience piece of, even if we are missing ways it used to be, we're still here. We have sensation now. What do we want that to look like going forward? And how do we help psychologically our physiological parts of our bodies adapt? So yeah, that's really lovely. Any final thoughts? And if not, that's fine. I would love for you to also just just remind people where they can find you if they're interested in either consulting with you or seeing you, or anything that you'd like to just put out there as far as to help you get your message across.
Sure. So I can see people in New York State. If you got boots on the ground in New York State, I am here for you. I'm at the Rochester Center for Sexual Wellness, and I work with a wonderful team of sex therapists. And in addition to sexual medicine, and I do menopause medicine and gender medicine as well. So I really take great reward in that work. The other thing that I want to make sure to mention is that if there are any professionals out there, or people who are patient advocates around cancer and sexuality, particularly in women and girls, there is an amazing organization, the Scientific Network on Female Sexual Health and Cancer, that brings together professionals from a wide variety of disciplines, as well as patient advocates, to kind of push the research forward and get the word out about how to help people with cancer and sexuality. And then on the men's side, the people with penises side of things, Sexual Medicine Society of North America is the place where that conversation is really happening. And so there are good resources out there if you are a professional or a patient advocate and you want to get involved.
Okay, wonderful. That's really good to know. We'll make sure and link to those in the notes of the podcast as well. So, well, Dr. Pebble Kranz, I'm so thrilled for your time with us today. Thank you so much for bringing all this awareness, and especially the medical aspects of stuff that I'm not always as on top on. So that was really interesting to hear. And thank you so much for your time with us today.
Thank you. I'm really pleased to be able to have this conversation with you.
Yeah, for sure. Thank you.
Thank you for listening to the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. To watch the video of this podcast, you can subscribe to Natasha's channel on YouTube and follow her professional Facebook page at Natasha Helfer, LCMFT, CST-S. You can also find all her cool resources at natashahelfer.com. The information shared on this program is informational and should not be considered therapy. This podcast addresses many topics around mental health and sexuality and may not be suitable for minors. Some topics may elicit a trigger or emotional response, so please care for yourself accordingly. The views, thoughts, and opinions expressed by our guests are their own and do not necessarily reflect the views or feelings of Natasha Helfer or the Natasha Helfer Podcast. We provide a platform for open and diverse discussions, and it is important to recognize that different perspectives may be shared. We encourage our listeners to engage in critical thinking and form their own opinions. The intro and outro music for these episodes is by Otter Creek. Thank you for listening.
There is a place where time slows to nature's pace, and there is space there to find yourself in her embrace. Some places should be left alone. Na tishki say the so we can always go to the homeland of the heart. Years of our human history etched on her canyon walls, alongside Earth's mysteries. Some places should be left alone. So we can always go to the homeland of the heart, to the homeland of the heart. Deep in our cities, we sleep without her stars, yet still her presence sustains us from afar. Some places should be left alone. No tishki so we can always go to the homeland of the heart, to the homeland of the heart, to the homeland.